Last lecture, long day. You all of you need to get back to your weekend, so let's rock and roll. Now again, colon cancer, like breast, one can go on and on. There's heck of a lot to cover, but I'm going to focus on some things that are on my mind, and we take it from there. Again, no conflict of interest, just interest. We have talked about dropping rates of colon cancer. For last several years, we have noticed that the colon cancer is on the way down. Maybe the colonoscopies are working. Maybe we are becoming a healthier country, whatever. But the most worrisome trend that appeared in last 2 months is that in young, which is 20 to 35 age group, the colon cancer is rising. And this is largely because of the teenage obesity in the United States. Insulin growth factor and obesity, JAMA has a new report that just came out that suggests that that's the one group where colon cancer was never a problem. And suddenly it is coming next to the testicular and the lymphomas and other things that happen at that age. Suddenly these are people, and the physicians are not thinking about it. If you get a 20-year-old with, constipation or whatever, they don't really go through colonoscopy or any major screening. So these are late diagnoses because people have missed the diagnosis. So this is important. As I said, this is a fairly common cancer. It still remains very common. This is the cancer that taught us about lifestyle and what we do. People who went to Japan and married Japanese women and stayed behind in Japan in 1945 after the war. By 1963, these Americans were dying of gastric cancer and their colon cancer incidence was gone. The Japanese who came here at the turn of last century and switched from fish and sushi to hamburger, steak, and potatoes, by next 50 years were dying of colorectal cancer, and the gastric cancer was gone. So it is not just who we are, but it is also what we eat. And that was sort of, this tumor brought it to our complete attention. So again, if you focus on young people's diet, besides the fact that they are obese, besides the fact that there is an insulin growth factor, the smoking is rising in the young. There is a degree of nonchalance about this. The other thing that is happening is that the diet, the junk diet that is in the campuses and all, is not exactly the healthiest thing. So there are lots of epidemiological interest, but it's also very worrisome because this is the only area in which colon cancer is rising. If you look at this graph, otherwise, all the tumors fell, and colorectal continued to fall over a period of time, men and women. The bump in the incidence was coinciding with the time when this country smoked a lot, and as smoking became no-no, the numbers fell. And of course, as the colonoscopy became somewhat prevalent, this is basically the trends of not only early diagnosis, but cure improved. There is tremendous progress in terms of treatment. I'm going to come to some ideas that I think I want to leave behind with you. But if you look at the disease-free survival here in stage 3 in adjuvant setting, it has gone from 50% to something close to 75, 76%. And that's a major, it's as important as adjuvant disease in breast cancer, because when you take colorectal cancer, colon cancer out, and you have a node-positive disease, the impact the strategies have made since 1988 have been impressive. I want to point out that the colon cancer has dovetailed the lowering rates, but there is a considerable concern that not just in the young, but rest of us is going to go up. So you look at this graph, we were all very thin and skinny in 1980s. This graph was completely blue. Less than 15% of population was even 10% obese. And by 2004, the country has turned red. And if you look at the projected numbers for 2020, it is absolutely horrible. Most states have more than 35% beyond the obesity level. So if the obesity is a driver for malignancies, several cancers, including breast and colon, will again uptick and start moving again. The pathways of colon cancer are twofold. There may be a germline mutation or a somatic mutation. There are syndromes like the hereditary polyposis, where there is a significant 80% chance of colon cancer in a lifetime. And then I want to bring up something else, which is Lynch syndrome. So all of you in the audience, nurses, nurse practitioners, physicians, we are doing a terrible job of finding people who are at risk. This is an area which we don't understand. The science and the jargon has been daunting. So I asked my colleagues and my students before I came for this conference, we had a whiteboard and said, go up there and show me, how will you pick up a Lynch syndrome? And they all sort of mumbled and drew, and some people who surreptitiously opened their iPhone and opened the NCCN guidelines. Board-certified oncologists were lost on what I was asking. It is an elephant in the room. This is the Lynch 1, Lynch 2. So Lynch is largely colon and family members with colon. Lynch 2 has other malignant sites. 3 to 4% of all colon cancers. And it's proving to be a major issue. So why am I concerned about it? Okay. In Lynch syndrome, you're going to have more than one tumor in the same person. So this is a person, if you found a tumor, let's say, at the end of the descending colon, and you take it out, you're obligated to completely do another colonoscopy on rest of colon, because there may be a second one lurking behind. So that's very important. This is also the tumor which is actually slightly better in terms of prognosis. So if you have it, then it's going to be less ferocious than a smoking red meat related colorectal cancer. What are the other tumors? This is a very busy slide, but endometrium is the second most common cancer. So we recently saw a woman, youngish woman with endometrial cancer, who had one brother with colon carcinoma, father had a colon carcinoma, and when we started screening her family, we found several other tumors, including one gastric. And these are all young people. So it's very important that you look at this list. We have endometrium, stomach, small bowel, hepatobiliary, ureter and pelvis, skin, pancreas, brain, hematological soft tissue, larynx, just case reports, not yet major. But if you are looking for history, you're looking for these tumors in an index case of colorectal carcinoma. So it's not enough just to say, you have any cancer in the family, anybody else has colon cancer. That's not an adequate history. Cumulative risk, if you look at a Finnish study where general Finnish population, if you have Lynch syndrome, 1.6% versus 82%. Endometrium, 1.3 versus 60%, and down the line. So it is pretty important. We had one patient with what we thought was Lynch syndrome. We started screening her, and we suddenly found that just a few months ago, her grandmother in her 70s was discovered with a very advanced endometrial. And there was an index case a little bit earlier who had colorectal carcinoma. If somebody had done a slightly diligent study, both these tumors would have been picked up. The grandmother was beyond any help because it was locally as well as fairly ferociously advanced. The young lady we saw was hopefully is cured and is on adjuvant treatment. By age 70, if you have Lynch syndrome, your risk of endometrial actually exceeds colon cancer. So, and again, gynae-onc is not in sync with medical onc or GI Joes. So again, they see their part, but they're not linking up with rest of us. And again, this is a question of not having enough shared information. So how do I recognize? I'm sorry this does not translate because I have a Mac computer at home, and some of these slides, when they try to go from Microsoft to Apple, there's a battle. There's always a battle. Make it simple for you. When you have this, so you have 2-3 guidelines which are published. One is called Amsterdam, other is Bethesda. But if you get a colon cancer specimen, ask for both immunohistochemistry and microsatellite instability. So if immunohistochemistry shows a diminished protein, which means one of the 4 germline mutation has happened, that's one DING, Seconding is if you have MSI, microsatellite instability, the seconding, refer the patient for genetic counseling because that's the way to find it. So besides having this history of index cases around which may tip you off, if you do this in every case, you're not going to miss. What they have basically said is that if you only use Bethesda guidelines, if you only use Amsterdam guidelines, you miss 25% of Lynch cancers. You lose Bethesda guidelines, you miss another 25%. If you use both together, you still miss about 15% of patients. It is believed that there are 15,800 new cases that are diagnosable in the United States. This is a very interesting slide. I've stolen it from a friend from another institution. They screened patients. 25% met neither Amsterdam or Bethesda guidelines, so they would not have been picked up on a questionnaire. And basically 44 screened positive for Lynch when they did both MSI as well as the immunohistochemistry. And by that calculation, if you extrapolate, there's a huge number waiting to be discovered. So we are not picking these people up. And keep your ears to the ground. This is something we should pick up. Going one step further, once you find the tumor, colorectal carcinoma, rectal carcinoma, most of them will require chemoradiation up front and subsequent surgery. Why? Because the rectal area is extremely closed. Great dissection is not possible. You better have smallest tumor possible, giving surgeon maximum chance for a curative resection. On the other hand, colon cancers are first surgeon's domain, and they are largely going to be cured with a great surgery. If the surgery is done, and they have taken at least 12 lymph nodes for analysis, and that quality of surgery basically is determined by not only the dissection, but number of nodes telling you how extensive the look and search was, then now you have a chance to offer node-positive patients curative chemotherapy. But it still remains absolutely clear that a first attempt to cure is going to be the surgeon's domain. And it doesn't seem to matter what technique your surgeon uses, whether he still goes for an open surgery and a very careful dissection, or he goes for a laparoscopic surgery, or he goes for a robotic surgery. Both Binay and I were used to both open surgeons in Chicago, as well as a brand new group that had the Da Vinci robot and would basically take testicles out of the ears. They would go through the ears and take the testicles out, or go through the testicles and remove the eyeballs. I mean, they were fantastic, and it was really scary what they could do. But the outcomes in terms of the success of surgery did not depend on the type of technique. So what I want to point out is that trial after trial after trial, and there's this little web page I have quoted, it doesn't seem to matter. If your surgeon is good at laparoscopy, his results are going to be good with laparoscopy. If they are the people who take out testicles from eyes, they are going to be good at it. And your surgeon is an old-fashioned guy who opens, goes in, and does a careful job, doesn't matter. It matters in terms of post-operative recovery, number of days, number of hours, blah, blah, blah. But cancer cure, identical. So it's a question of skill, experience, and comfort. Doesn't matter what technique they use. This is pretty crucial because in medical oncology, patients come and say, maybe cancer came back because they didn't do it robotically, or maybe because they did robotically, they maybe didn't see what they were removing. That's not really true. Bad biology, like in breast cancer, will come back, and the surgeon can only do so much. What they can see, what they remove, margins, and that's about that. Then you come to the question, okay, you took the tumor out, you are going to have a strategy for cure. What do? How do you take care of the micromets, and how do you lead that patient for cure? So in adjuvant, basically there has been a whole bunch of thought. And many years ago, 1988, 5-FU levamisole. Levamisole was an anti-parasitic drug, 3 days out of 15 days. So 1, 2, 3, 15, 16, 17, you would take levamisole capsules, and you would be on 5-FU. Slightly effective, much better than doing nothing. Pretty soon, 5-FU leucovorin arrived, and then in succession, oxaliplatin and all other agents. It's important that in those trials, irinotecan did not succeed. So you never use irinotecan in adjuvant setting. We were also very hopeful that the new gizmo drugs, Avastin or Erbitux, would soon enter adjuvant arena and improve the picture even further. As I'll show you in a moment, that did not pan out. Wherever you use 5-FU, you could use oral capecitabine. The results are identical, and it saves a lot of grief in some ways. So, what are the poor prognostic factors? The poor prognostic factors are renal node involvements, more than 4 nodes, tumor penetration through bowel walls, adherence to surrounding organs, perforation, obstruction, very high CEA before surgery, lymphatic or perineural invasion, BRAF mutation. Remember, BRAF mutation is in melanomas. Any tumor, breast cancer, lung cancer, you see BRAF, you know it's bad news because the biology is similar to the worst tumor on the planet, and it changes the whole ballgame. Anything you are going to use in chemo, BRAF is not going to work. You need another strategy. Obesity, 2 reasons. One is obesity is a bad risk factor, comorbidities, and surgical adequacy is not that great. Very, very obese patients, the immediate surgical difficulties are phenomenal. So that's there. And of course, like everything else, what is at the cellular level? What's the gene profile? I want to point out a few things here. Can you keep track of me? And maybe if you need to record also. All right. So, what about those who are node negative? Can we improve our survival of colon cancer that is resected but is node negative? And few suggestions there. One is that this particular study sort of combined stage 2 and 3, so whatever conclusions they came in with were sort of not completely acceptable to me because you were really not looking at the same stage. It did show some benefit. The important thing, I'm going to skip some of these slides and go to where we are. Unlike in breast cancer, the genomics analysis, the oncotype for colon cancer, has not worked out to predict treatment. So you basically, if you have a oncotype study done on colon cancer, you will get a prognostic information. Is it good or bad? Will it recur or not? Is this a bad tumor or a good tumor? It will not give you hint on should they get aggressive chemo or not get chemo. So get that so far, that is very clear that does not give us a predictive information on who gets treated, how do they get treated. So that's important. And that's very important for stage 2 because we were starting to believe that maybe if we did recurrence score and they were node negative, but the recurrence score was high, maybe we should slip in 6 months of chemo. Not true. Trials are necessary. Whole bunch of trials quoted here. Again, common sense dictated that that's how it will go because that's how it went in breast cancer. It did not. So basically, in stage 2, when would I still consider fairly large lesions, perforated lesions, obstructed lesions, lymphovascular invasion, maybe perineural? So these are the things where I might discuss with patients, saying I'm going to give you 6 months of 5-FU leucovorin. Is it always beneficial? What do the guidelines say? Guidelines are sort of mumbling at the stage. They are not really very definitive. If you do MSI, and I suggest in stage 2 you must do MSI. MSI is the microsatellite instability. So you look at the tissue, and there are islands where DNA is unstable. These islands crop up as MSI. So these are the mismatch repair genes. This is a gene that basically when a cell is damaged, they go and repair. There's something to do with the internal repair system. And when these genes are damaged, you have a microsatellite instability. So look for it. Now, once you find MSI, and if you have MSI-H, which is the high version, they do not benefit from chemotherapy. These are the people who will not spread beyond where the tumor was, are not into nodes, not into liver, and they certainly do not have any reason to get chemotherapy. Is that true for stage 3? We don't know. That data is waiting. But for stage 2, it's pretty clear. So stage 3, the data has been, again, chemo versus no chemo, there is no doubt. You have node positive disease, you need something. What do you need? Do you need FOLFOX in full form? Do you need FOLFOX beyond something? Can you add bevacizumab or cetuximab to it? And who doesn't get FOLFOX? Again, this is standard risk stage 2, no benefit. High risk stage 2, no benefit. So at this moment, if I were to be quoted, I would say that unless you have an obstruction or a perforation before surgery, during surgery, if you have even intraoperative perforation, tumor is spilled, and you probably are better off giving chemo. Rest of them outside a trial should not get chemotherapy. All right. The sobering reality that we thought that if these drugs were great in metastatic setting, bring them up, bring them forward to adjuvant, they'll be great. Didn't work out. If you add Avastin, except for additional morbidity, nothing seems to happen. Same thing with Erbitux, same thing with irinotecan. Interestingly, Binay, the data seems to be that in MSIH that I described, that's the only group that seems to benefit from irinotecan. So it says that's the version. If that was the only thing that was tested for adjuvant therapy, they would have found that cetuximab works in this particular setting. But that wasn't known 15 years ago. And I don't know if anybody will do that trial now, because that question is sort of moot. But for the moment, the great drugs that came for metastatic setting seem to be completely ineffective in adjuvant setting. And I guess that's why we do clinical trials, because I remember I used to speak for Genentech as well as the Erbitux people, and I would go around the country and said, the great drug, waiting for this to be tried in adjuvant setting. Imagine the cure rates. Well, the cure rates didn't go up. Only thing we got was money cost and side effects. So yeah, it's important to do trials because, again, here common sense didn't work out. Stage 2 tumor, low risk, no treatment. Standard risk, no treatment. High risk, discuss. And high risk to me is right now obstruction or perforation. I'm waiting for much more clearer molecular guidelines which may come over the next few years. I want to also point out one other thing. So, at the moment, in stage 3, or node-positive disease, 6 months of oxaliplatin 5-FU leucovorin. In patients over 70, there doesn't seem to be a benefit. So you have an elderly patient, oxali is pretty high risk, just go with 5-FU, and you'll be fine, or Xeloda. And again, the stage 2 remains a question mark, so be very careful there. These are very difficult treatments to go through. Every 2 weeks, trying to go through a 42-hour infusion, and the neurotoxicity of oxaliplatin is unacceptable. I want to go into another area, which is the metastatic disease. Metastatic disease, once you come to that point, first question I want to ask again is, what was the adjuvant strategy? Did the patient have a node-positive disease? Did you give the patient FOLFOX? And how many years ago was that? Let's say, like Herceptin, patient was just finished with adjuvant or progressed while on FOLFOX. You know that oxali is not going to work here. You have to move to the next paradigm, in which case I would immediately move to FOLFIRI if I could. Otherwise, how do I choose between FOLFOX and FOLFIRI? Irinotecan gives diarrhea. So if you have any reason for having diarrhea, irritable bowel syndrome, short bowel syndrome, ulcerative colitis, men and women who react to nervousness or tension by diarrhea, these are the people who will have diarrhea on irinotecan. You avoid FOLFIRI as the frontline drug. On the other hand, those who have neuropathy already or might get it, diabetics, lupus, avoid oxaliplatin and give FOLFIRI first. Tourniquet proved that whether you use FOLFOX first or FOLFIRI first, whether so long as you use one after the other, the survival is same. It doesn't matter what you use first. So choose based on quality of life, choose based on what side effects you want to avoid. Bev first line, and then Bev continuing through second line. So sometimes you start bevacizumab with FOLFOX, patient progresses, and now you are switching to FOLFIRI. Do you continue bevacizumab? At this stage, what do I do? So I do two things. If patient was KRAS wild type, I will switch them to a Erbitux-based treatment because that's their best chance, and I'm going to quit on bevacizumab. On the other hand, like triple-negative tumor, they were mutated KRAS and the Erbitux or Vectibix are not an option for them, I will continue bevacizumab and switch to FOLFIRI. Or if I was on FOLFIRI, continue on FOLFOX, but continue bevacizumab. So BBP stands for bevacizumab beyond progression. There is a role for it, good data, but if I have a KRAS wild type, I would sneak in cetuximab in between because I want to make sure they get that benefit. Capecitabine can replace 5-FU in any of these protocols without the loss of efficacy. Erbi plus oxali is not a good idea. So anytime you are thinking of adding Erbitux, you better be a irinotecan protocol. At least the trials has done so far have shown that FOLFOX plus Erbi or oxali Erbi alone as a combo is not a very functional idea. People still do it across the country if you see. The Erbi is added to FOLFOX because American oncologists are stuck on FOLFOX as a default program, and not everybody is looking at this data. Oxali without some kind of 5-FU compound is not a good idea. Again, I see this across the country. Patients are presented to me. They are on oxali alone every 3 weeks. Okay, what's the rationale? What's the data? It does not work in metastatic colorectal carcinoma unless you have capecitabine or 5-FU to maximize its impact. So very important. Vectibix and Erbitux are similar, but Vectibix is completely humanoid antibody, whereas that is partial, the cetuximab. So cetuximab has more chances of reactions, acute reactions, and Vectibix seems slightly easier to give. Are the outcomes and basic control rates similar? Yeah, the Vectibix somehow came about 5-7 years after Erbitux. Their first mistake as a company was they took people who had taken every treatment and then gave Vectibix versus best supportive care and showed that best Vectibix was slightly better than best supportive care. Well, what does that mean to most oncologists? Before hospice, everything is tried, patients still want something, you got the hospice people already knocking on the door, let's try Vectibix. And of course, at that stage, nothing works. And if they have failed on Erbitux, they will fail on Vectibix. These are similar compounds trying to go for the same EGFR. It doesn't make sense to use it at that stage. So it's a good product. It was sort of brought in late and is now trying to catch up in terms of proper trials. Again, one versus the other is not clear because both companies, for their own reason, will not go head to head. They will keep testing against something else. They don't want to find out. So this is Vectibix. There is data against best supportive care. In KRAS wild, the data was pretty impressive, and so that's where it should be used. I like this drug. This sort of came in an era where we had all basically thought that it's over. There are not many new anti-colon cancer drugs are coming. This was basically, for 10 years I was presenting bevacizumab slides, and I would basically have a slide on something called VEGF trap. And the idea was very attractive to me. Basically, this molecule would go and trap vascular endothelial growth factor around the tumor and in the blood supply, trap it so that it does not work. And the trap sounds so good, you almost visualize the thing being trapped. And so exactly that's what it does. It's the pharmacological name is Zeltrap. It is bound to IgG, so it sort of sits around and moves around bound to this IgG, and it's a recombinant fusion protein. The way it's approved is the way it was tried. So it used to be used with irinotecan and 5-FU. It's not used alone. And when it's toxic, it's pretty toxic. So the main side effects is pancytopenic. Avastin has no marrow side effects, whereas VEGF trap, surprisingly, and nobody knows why, can produce neutropenia, thrombocytopenia, and anemia, fairly severe at times. There is a diarrhea, and of course, like all of these VEGF drugs, hypertension. That hypertension responds beautifully to lisinopril. So I just want to put in a word that when you are sort of running out of options and you still have a patient that is looking for treatment, this is an option. That's how it's approved, and that's how it's used. This is, again, before hospice, but much before hospice drug. This is Stirvaga or Regorafinib. This is the only oral drug besides Xeloda. It's an oral TKI. The side effects are liver, fairly severe sometimes liver problems. Again, hypertension, bleeding, hand-foot syndrome. Very interesting. Just like Xeloda, it causes a hand-foot syndrome. This hand-foot syndrome, like Xeloda, is maximized in people who live in hot climates or have a lot of sweating or eat a lot of spicy food. So those of you who had fajitas in the afternoon, you know, so my patients, I'm in Phoenix, and my patients eat very hot food. And if they quit hot food, the hand-foot syndrome manifestations are much lower. But if they continue the jalapenos and other things, the hand-foot syndrome, because things are secreted on the skin, under the skin, and what they feel, the symptomatology seems to be exacerbated. And the same thing I've seen with 2 patients on Stirvaga. This is used, the way it's approved by FDA, it's after oxaliplatin, irinotecan, bevacizumab, and or Irbi. So you basically, the way it is to be used is after you actually used other. It's pretty easy to use. The patients, in spite of the fact that these are major warnings, the patients I have taking, 2 of them have 2 patients have fairly well stabilized. They have entered what is called a stable disease phase. The symptoms are gone. The scans are not changing. The CEA hasn't changed, and sort of the storm has subsided, but when you look out the window, it doesn't look completely clear. So we don't know how long this will hold, but yes, there is an option. So this is the study that came in ASCO. Finally, panitumumab or Vectibix was tried in a formal trial with FOLFOX, so FOLFOX versus FOLFOX plus panitumumab, and they did show a slight but impressive efficacy. It's a pretty confusing area because you have so many drugs. There's no question that before all these drugs arrived, median survival was 8 months, and today it's about 35 to 38 months. So we have brought it to a chronic disease state. Half the patients will live beyond 3 years, which is great. Before 5-FU, or only when 5-FU was available in 1995, cost of treating a metastatic colorectal cancer was $500. Today it's crossing $350,000 and counting. I don't exactly know what the last 2 drugs I described cost, but I think they cost more than a Mercedes every month or something. So that's another interesting thing about oncology drugs. Last 2 years, every new molecule has come at a jaw-dropping price. Just, Avastin, when it was introduced at $6,000, we thought it was expensive, and now it seems like chump change. Some drugs have come in at $90,000 a dose. So it's another thing that is basically, yes, patients want it. There is a prolongation of life, but somewhere along the line, somebody will have to also look at what it is costing, because it's basically getting out of hand. So my take is, current standard of care, first-line treatment, metastatic colon cancer remains 5-FU-based chemotherapy plus bevacizumab. FOLFOX or FOLFIRI, Xeloda, Xelox, Xeliri, I don't care. This is where. Is FOLFOX plus Xeliri, yes. Xelox, yes. Would you use FOLFOX beyond bevacizumab beyond progression on FOLFOX? The data suggests you could do that, but as I said, if you have a KRAS wild type, I would prefer that you give the patient a chance to use Erbitux. Bevacizumab or Avastin, one great thing is it works whether the KRAS is wild type or mutant, so that is really good, because no matter what type you have, and the mutant colorectal carcinoma is like triple-negative breast cancer. It's diminishing options. You already have all the KRAS drugs gone, and you are sort of left with fairly difficult treatment protocols. So it's important to know that that is not affected. And treating to progression may improve survival. So at every paradigm, if you wait until progression, the patient does want more treatment and is physically capable of, go on to the next paradigm. Only way you will get to median survival of 4 or 5 years is if you give patient chance sequentially to try most drugs, which means that the cells that survive seem to be resistant to the prior paradigm of drugs. And you use something else, and a new clone dies, and now you're left with some other bad boys that require something else. And I have friends who basically have, after 3, 4, 6 cycles, have come back to FOLFOX and eliminated remaining tumor because now the clones have come up which are now suddenly sensitive to oxaliplatin. So there is plenty of room in terms of experimentation. It's a long process. The patients, as their performance status worsens, more and more drop off and want hospice, which is why some of the good agents you want to use up front, because you don't really know how long patient will want to go and how long you will continue this. Role of EGFR inhibitors in first-line treatment is justifiable. Anti-EGFR antibody, when added to oxaliplatin in KRAS mutant cells, it actually may be detrimental. So there are earlier trials, it was being used in mutant as well as wild type. It's a terrible idea because it's not just that it didn't make an impact, I think it worsened the prognosis. Can you use cetuximab and irinotecan? Yes. Can you use cetuximab, irinotecan, and panitumumab? Yes. Can you use oxaliplatin and cetuximab? Data says no. So across the country, half the oncologists polled say yes, they use ERBI with FOLFOX. Not a great idea. Can you use panitumumab? The data says yes. So if you want to use FOLFOX and you want to use something that is, patient is KRAS proper, I think the Vectibix is the drug to go because there's data. There is positive data. Can you combine Avastin with anti-EGFR antibodies? Cetuximab, no. Panitumumab, no. So while it seemed like a great idea that you block EGFR and block the blood supply and the tumor dies, that has not panned out in trials. In fact, it's detrimental, and the response rates are much worse. I'll stop here and leave some time for questions. Thank you very much.